side? Can you just, yeah.
Okay, yeah, I'll try. If I get stuck, I'll let you know. Okay, good afternoon, everybody. Thank you so much for joining us, and a special welcome, obviously, to Steve Spellman. Thank you, Steve, for coming in here and giving us this talk, which I think is very valuable. I've heard you talking in different places and with WMDA and education forums. So I think it's very apt for our group, especially our fellows that are up and coming to be exposed to your talk today. And it's the clinical relevance of HLA-DPB1 T-cell epitope matching in donor selection with some case studies. I want to just introduce Jane as well quickly. First of all, Jane, as you know, has been with the registry many, many years, and in fact, close to 15 years experience with donors and with registry work. So she will do an introduction in interpretation of our reports, um, and then we will move on to Steve's talk. Just to mention, Steve is the Vice President of Research at CIBMTR and NMDP, Clinical Services Department, and he's a Senior Scientific Director at CIBMTR, which, as you all know, is the Center for International Blood and Marrow Transplant Research. His research is focused on immunobiologic and immunogenetic factors that influence outcomes following hematopoietic cell transplantation. So I think it's going to be a really lovely talk, but I think we can move on. Just there are some housekeeping rules and just some general information to share before we start doing the talks. Oh. Thank you. Thank you if you can move them. I tried moving, but nothing seemed to happen. So this is the deep dive management team, and a big, big special thank you to Blood SA and the deep dive team leader, Estelle, for all the hard work, Taryn, Michaela, and Melinda. Thank you so much for everything you do. Next. Okay, all our talks are recorded and are going to be available on the SA Blood website under resources and under deep dive. Please do mute yourself during presentations because we don't want everybody hearing what you're up to. And then CPD points, as you know, Health Professions Council for South Africa, you do need to give your MP number when you register. If your MP number is entered incorrectly, you obviously will not receive your CPD points. So it's important for you just to make sure that you have done that correctly. Next. Next. Okay, there are some upcoming events. There's a very important one coming up, SASMO and SASETS. That's right this next week. So a lot of us will be heading up from Cape Town that way. Those people in Gauteng are obviously already there, and there are a whole lot of very special international presenters as well. So don't forget about it. And then there's something new, the 6th National Cell and Gene Therapy Conference and Heritable Human Genome Editing Conference. And that's happening at the end of October. So if you can keep that in mind, and that's University of Pretoria. So here, back to the agenda, and I'm going to ask Jane to share her slides, and then she can just let Steve take over from there. And again, Steve, thank you so much for agreeing to do this talk for us. We really appreciate it. So Jane can start. Jane, you are muted.
I realized that. Apologies. Let me share again. Okay, good afternoon, everyone. Thank you so much for allowing us to present today. I'm just going to give a short overview on how to interpret a WMDA search and match service report. So if you've ever had a search done by the South African Bone Marrow Registry, in the search results that you would have received, you would receive something exactly like this. And I'm just going to go through on the important characteristics when doing a search. And apologies if you hear background noise. Our neighbors decided at this time to do weed heating. So the first thing you'll notice right on top of the report is the patient number, and this would be the number that is generated from our system, and it is unique to the patient. And this is and it de-identifies patient name, etc., and to ensure that we comply with both POPI and GDPR. Next thing you'll see is that this is a 10 out of 10 match search. In other words, it's HLA-A, B, C, DR, and DQ that they are matching towards. If we did a mismatch report, it would say 9 out of 10 or 8 out of 10. And donor search, so that we're doing a donor search. We could potentially also do a cord blood search. So if we did a cord blood search, it would say cord blood over here. And it indicates that there are 15 potential donors for the patient that we're doing a search on. This is the section where you'll see the patient's HLA results, as well as the gender of the patient, the age, and blood group of the patient. Next, below this line, you'll see all the matched donors, potential donors, and generally it gets categorized from the best donor, in other words, the youngest donor, through to the oldest donor. As you'll see, this mentions that this is a US NMDP donor. And on this side, you'll notice that this is the match grading. And this donor is 100% matched for the patient above. In other words, 10 out of 10 match, no mismatches. This is the GRID. So GRID stands for the Global Registration Identifier for Donors. It is a globally unique identifier that was introduced by the WMDA. So each donor has a unique identifier. The first 4 digits is called the ION, and that is unique to each registry. This is 3553, the NMDP's ION. Our ION, for instance, is 8118. The middle numbers are your donor, unique donor registration ID, followed by the 2 last numbers, which is the checksum. You'll also then see that this donor is available. If the donor was reserved for a patient, it would say RS. CMV indicates the CMV of the donor. In this case, the donor is CMV negative for IgG, negative for IgG, and the last time the donor had the IgG tested was in 2021 in May. Indicates the patient's ethnicity. In this case, the donor is Caucasian. Also indicates the gender of the donor, age, and blood group matching. At the top here, if, for instance, we had patients, and this happens sometimes where there is a patient that has maybe 15 or 20,000 matched donors, we can then filter and for the patient's blood group. So you have matched donors that are blood group matched, gender matched, or even CMV matched. So we can do this if there is a lot of donors that the transplant center has the ability to choose from. And the tick here next to the ION of 3553, you'll see that this indicates that the NMDP is WMDA accredited. So registries that are accredited by the WMDA will have this green tick. If you are in the certification process, in other words, if you're getting towards your accreditation, it will be a different color, yellow tick. And if there's no tick, it means that the registry is not WMDA accredited. And so if, for instance, moving on, so search match results with incomplete or mismatched donors. So this is what the report would look like. The report I just showed you was a fully matched donor, which is what we want to see. But sometimes we do have reports where there is mismatched or incomplete typing. And I'll just go into a little bit more detail on the percentages on the match probability. So if, for instance, this donor was a potential match for a patient and we did a 10 out of 10 search, The 0% at 0 indicates that there is a 0% chance that this donor will be a 10 out of 10 match, and also indicates that a 9 out of 10 match is also not going to be available. There is a 15% chance that this donor will be a 8 out of 10 match. So the likelihood of finding a match donor is very low, and it will obviously change for each patient that it sees. It's the algorithm that the system works on. This indicates, so the 5 squares are your HLA-A, B, C, DR, beta 1, and DQ beta 1 that is being matched. And if there is a green, it means that it is an allele match or an identical antigen recognition. In other words, your antigen O2 and O2 antigen and O2 allele is identically matched at the recognition. Blue means that there is a potential allele match. So there is the antigen is a match, but because the allele is either at intermediate stage or low resolution, it may or may not be a match. But at this moment, they're saying that it is 100, that there's a good chance that it will be 100% match. The orange indicates that there is an allele match, but there is an antigen match. In other words, the 41 is a match, but the intermediate, or the 5601 at the 01, is going to be an allele match, mismatch, I should say. And then lastly, red means always bad, antigen mismatch. So that means that the O2XX, the patient may have an O1, so which means the O2 is a mismatch. And then I'm just going to quickly touch on DP-beta1 matching before Steve takes over to do his presentation. So in a search match and connect service report, if it's green, it means it's permissive, so that the mismatch is a permissive, and that is a good sign. If it is red for H, it means that the red is a non-permissive DP-beta1 mismatch in the host versus graft direction. And if it's a red and it is a G, it means that it is non-permissive DP-beta1 mismatch in the graft versus host direction. And that is all from me, so I'll hand over to Steve.
Thank you, Jane.
All right, thanks, Jane. And thanks, Charlotte, and thanks everyone. Thanks for the opportunity to present today. So let me pull up my slides. And thanks, Jane, for that nice overview of the search and match system. That was, and I like the clear color coding, makes it very intuitive, and appreciate that. And the host versus graft and graft versus host directionality, it's a nice addition. So I'm going to jump right in and talk more about the clinical relevance of HLA-DPB1 T-cell epitope matching in modern donor selection. And so this is an extension of a talk that I gave earlier this year to the WMDA education program. And so I have incorporated some details from our recent donor selection guidance that was published just last year in the Journal of Transplant and Cellular Therapy. And that's a collaborative and consensus opinion that came out of experts from the CIBMTR and the NMDP. And we published that on a periodic basis. So the last version was from 2019, and I'll touch on that here. And so really focus on the 2025 and kind of where the field is going in the future. So by way of outline, I'm going to cover some background on HLA-DPB1 and T-cell epitope matching in allotransplant, kind of how that's evolved and how our thinking's evolved over time, especially with the advent of new evolving GVHD prophylaxis strategies, mainly in the US, and what we've seen in Europe as well. And implications that has for application of matching at HLA-DP in the donor selection strategy. And so kind of incorporating that into our NMDP CIBMTR HLA matching guidelines. And then we'll talk through 3 cases where we apply this in different GVHD prophylaxis settings. So let's just go ahead and jump right in. And so by way of background, these are data from a seminal publication from Dr. Stephanie Lee that was published through the Immunobiology Working Committee of the CIBMTR back in 2007. This was one of the this is a work of pride here. This was one of the very first studies that I led as the scientific director of the Immunobiology Working Committee of the CIBMTR. And so this was a culmination of over a decade's worth of work where we captured samples within the CIBMTR biorepository on patients that were proceeding to transplant. Through the NMDP, we captured pre-donation donor samples and conditioning patient samples and did a validated high-resolution HLA typing on each of those. So typing for HLA-A, for class 1 and HLA-DRB1, DQB1, DQA1, DPA1, and DPB1 in the class 2 setting. And so this was one of the very first publications that demonstrated that, well, first of all, matching at HLA-A, B, C, and DRB1 at the allele level is important for survival in the calcineurin inhibitor setting. This was transplants that were mainly performed before 2000, so mainly for chronic myelogenous leukemia, which frankly is a disease that we just don't treat that often anymore due to the effectiveness of TKI therapies in the modern era. And what we demonstrated here was that with each subsequent mismatch, so a mismatch at A, B, C, or DRB1, led to about a 10% decrement of survival out to 1 year and then out to 5 years. And that followed with a 6 of 8 match. After this paper was published, we saw very few 6 of 8 matches that were being done anymore. And frankly, 7 of 8s were not as common, really just being done when there was no donor. So this was your donor of last resort, essentially. And so really showing that impact that you had from an HLA mismatch. Now we did look, like I said, we looked at HLA-DQ and DP and their alpha subunits. In both HLA-DPB1 mismatches in these analyses were associated with an increased risk of acute GVHD, but we didn't see any associations with survival. And this is using traditional allele level matching at the DP locus. We did not see an effect of DQB1. And this kind of set the standard, at least within the US, to consider an 8 of 8 match. DQ being less important, and DP, well, having poor linkage and unlikely to be able to match, and having very little impact on and not really having an impact on any survival outcomes. So even with the additional risk of acute GVHD, that isn't contributing to higher rates of mortality. Now, the Fleischauer group originally was in Milan, and then it's currently located in Essen, had been doing some work on what they were calling T-cell epitopes. So this was all based on in vitro work, doing mixed lymphocytes cultures between DP mismatched groups. And that what they observed was that there were different groups that they considered T-cell epitope matched, where they led to sort of a permissiveness between those mismatches. There was no alloreactivity that was noted in vitro. And so they characterized all of these DP mismatches into T-cell epitope matched, permissive, those that were permissive and those that were non-permissive, and the non-permissive leading to higher rates of mortality post-transplant. And this was one of the very first large studies that utilized the International Histocompatibility Working Group data set, which CIBMTR contributes to, as well as many other centers throughout the world, and demonstrated that an HLA-DPB1 non-permissive was associated with a higher risk of mortality post-transplant. Now, we took this forward into a CIBMTR cohort in 2014, validated that finding, where the permissive did better, fully matched, and non-permissive kind of did about the same. But the permissive group did lead to higher rates of survival post-transplant. And so we incorporated this into our recommendations around donor selection. But at the same time, we were also doing some work to understand those donor factors that are selectable. So not just your HLA match, but then prioritizing, say, sex match, age, younger age, CMV status, other factor, ABO, other factors that could be considered in the donor selection process to try and understand those various risk factors and how you kind of come up with a holistic approach. Now, this was a study that utilized a cohort of fully HLA 8 of 8 matched, mainly looking at AML, ALL, and MDS from this time frame, so from 1999 to 2011. We split that into a training and testing cohort, and we looked at factors that were significant in the testing cohort and built a score. Those were DPB1 T cell epitope, donor age, CMV match, ABO match, and then tried to validate that in our testing cohort, and we weren't able to show an association here. And so we kind of took a step back, pulled the entire cohort together and said, well, what are those donor factors that are important? And we didn't come up with a validated score. We looked at a more contemporary population. And really the only significant factor in the training and testing sets was that younger donor age mattered. And that was at this kind of linear description that we see here. So for each change in about 5 years of age led to about a 2% decrement in overall survival post-transplant. And this was seen as a linear effect. Well, then that's great, but then that makes you focus on the youngest donor that you happen to have, and an 18-year-old being that donor. And frankly, there's very few 18-year-olds on the registry, and they just tend to get older each year. So your pool of donors is too small. So that's an issue, and we'll talk about that a little bit more as we kind of go in through some of the additional analyses that we've done on those donor factors that are important. But taking all of these findings and putting that into our donor selection guidelines that was published in 2019, led by Jason Dean. So 8 of 8 matching is kind of your top selection factors. There have been some permissive mismatches that have been described in the 7 of 8 setting, mainly HLA-C0303 versus 0304 if present. Then selecting your younger donors. And now the younger the donor available, the better at this time frame. And then considering permissive mismatching. And this is all in a calcineurin inhibitor-based GVHD prophylaxis setting focused on matched and single mismatched unrelated donors. These findings have been validated in many different settings, in the setting of bone marrow, peripheral blood stem cells, whether it's myeloablative or reduced intensity conditioning, whether it's a pediatric or adult population, or malignant or non-malignant disease. We've seen consistent findings with HLA matching using these GVHD prophylaxis approaches. And so that led us to kind of prioritize here, but putting donor age above DP status, because DP was not entering into those larger modeling studies that were done. Now, we've gone a bit further and looked at more recent contemporary populations, again, looking at those factors that may influence transplant outcome. And here we considered a 2 time to event outcomes separately for their trade-offs. We looked at overall survival as our primary, and then event-free survival, considering death, relapse, graft failure, rejection, or moderate to severe chronic GVHD. And you applied a newer, more novel advanced machine learning regression methodology based on non-parametric failure time Bayesian additive regression trees, or the BART methodology. And what we found here, and so this took a cohort that was more contemporary, so 2016 to 2020, looking at, or to 2019, looking at all diseases, but now the vast majority receiving calcineurin inhibitor-based GVHD prophylaxis. Again, these were all matched unrelated donors, so kind of keeping our donor source constant, and then setting that match level at an 8 of 8 match at HLA-A, B, C, and DRB1. And then we considered age, donor sex, donor parity, CMV status, and then other HLA loci, so DQB1 and DPB1 TCE permissiveness. So the results, what we found was donor parity, CMV status, DQB matching, and HLA-DPB1 T cell epitope permissive matching were not associated with greater than 1% improvements in overall survival or event-free survival. So that was the threshold, a rather liberal threshold for impact on outcomes. So 1% improvement in overall survival out to 3 years post-transplant. So only donor age met that criteria for overall survival and event-free survival, and then donor sex for event-free survival had clinically meaningful impacts on outcomes, and then were considered for donor optimization. So donor age impacts were more important for overall survival than event-free survival, and generally younger donors 18 to 30 were optimal. And why that's important, as I mentioned before, our 18-year-olds, maybe less than 50,000 on the registry at any given time. When you're considering 18 to 30-year-olds, just on the U.S. registry, we have over $1 million or 1 million donors that fit that criteria. So gives that opportunity to optimize. When you consider donor sex impacts, donor sex had very little, if any, impact on overall survival. Meaning, don't unnecessarily restrict your donor pool by saying I'll only take male donors. You're just throwing away half the registry, and frankly, half the registry that's more likely to respond when they're called to donate. So I would encourage people to not limit their choices. And then donor sex did impact event-free survival. But this suggested more of a preference for male donors due to lower graft failure risk. And this speaks to more to size disparity between donors. As long as the donor is of sufficient size to deliver the graft that your patient needs, sex is irrelevant in that equation. So now looking at the impact of overall survival, we created this waterfall plot of predicted overall survival differences at 3 years post-transplant for an 18-year-old, so that's our baseline here, set at 0 for reference, and then compare different ages. And so this was all through this Bayesian additive regression tree modeling, demonstrating that at the age of about 31, we start to cross over what the statisticians termed the zone of indifference. And so that's that 1% impact on overall survival after 3 years post-transplant. And so we start to cross over that threshold at about the age of 31. So donors 30 and younger all had essentially equivalent outcomes to an 18-year-old donor in this setting. So compared to 19 to 30-year-old, an 18-year-old donor choice produces benefits that are negligible and fall within that zone of indifference. So kind of saying that all donors 18 to 30 are essentially equivalent. Now, how does this apply in other settings? So I've kind of focused just in unrelated donors for the time being, but there's also the opportunity to optimize DP matching or DP mismatching, in this case, in the setting of haploidentical transplant. And so this was a study out of the Immunobiology Working Committee of the CIBMTR that was published in 2021, looking at the influence of HLA match and mismatch in haploidentical transplants. So the vast majority of these patients were mismatched for an entire haplotype. So mismatched at A, B, C, and DRB1 and DQ and DP for an entire haplotype to the patient. And what we found was that HLA-DPB1 T-cell epitope mismatching was actually beneficial. So selecting for those that were mismatched or non-permissive mismatched led to better overall and disease-free survival. DRB1 GVH vector mismatches impacted relapse and disease-free survival. And HLA-B leader influences overall survival and non-relapse mortality, and HLA-C influences chronic GVHD. Now, that's only in the haplo setting, and we've evaluated this in unrelated donors, and we don't see a similar effect. So this was a study that was led by Shannon McCurdy at Penn through the Immunobiology Working Committee of the CIBMTR, published in the Journal of Transplant and Cellular Therapy just last year, looking at post-transplant cyclophosphamide and the impact of DPB1 mismatching in unrelated donor allogeneic transplantation. So this was looking at a fairly contemporary population, first transplants from 2015 to 2020 for acute leukemia or MDS. HLA-DPB1 TCE mismatching was not associated with any outcomes in the PT-Cy setting. Now, PT-Cy or use of post-transplant cyclophosphamide has become the most common GVHD prophylaxis strategy used in the US. For mismatched unrelated donors, it's roughly 90% of all transplants that are being done today. In the matched unrelated donor setting, it's about 70 to 75% of all transplants that are being done today. In the haplo setting, it's been nearly 100% for about a decade. But this is slowly it's quickly making its way into the unrelated donor setting as well, and is substantially reducing GVHD risk and mainly showing benefits in better GVHD-free relapse-free survival. So survival in the absence of relapse, without severe acute GVHD grades 3 to 4 or moderate to severe chronic GVHD requiring systemic immunosuppression. And that's where we see the majority of those benefits. Now, in the calcineurin inhibitor setting, we still see some impacts of DPB1 matching, but that's mainly an increase in acute GVHD, as we've described for a couple decades now. So what does this mean in the unrelated donor mismatch setting? So that was matched unrelated. So we've kind of talked about haplo, we've talked about matched unrelated donors. Now what about mismatched unrelated donors? And so this was a study that was recently presented at the EBMT earlier this spring, looking at the influence of HLA mismatch locus on outcomes. So there's been some differential reporting within the CIBMTR and the EBMT, where within the CIBMTR, we saw that those that were 8 of 8 matched had equivalent outcomes to those that were 7 of 8 matched, and DP and DQ matching did not matter. Whereas in the EBMT data set, they did see some increased risk of mortality with class 1 mismatches, even in the post-transplant cyclophosphamide setting. Now, there's some differences between those populations that were evaluated. The CIBMTR cohort was a bit more homogeneous, was more recent transplants, 2017 to 21. Very little use of anti-thymocyte globulin. We rarely see that used in combination within the US with a post-transplant cyclophosphamide-based GVHD prophylaxis approach. And that's mainly anecdotally, that's mainly because the physicians feel that it is too immunosuppressive to layer on another immunosuppressive agent on top of post-transplant Cy, besides a calcineurin inhibitor backbone and MMF. Here we restricted to 7 of 8 mismatches and just acute leukemia myelodysplastic syndrome. The EBMT population was a bit older, 2005 to 2020, much higher use of ATG in the setting of PTCy, so 24% versus 2.5% in the US. They included more mismatches, so did allow for like 6 of 8s. And more mismatching at DQB1, and they included more diseases. So we decided we wanted to look at this again in our population, and so we extended this cohort, adding 2022 and 2023 to our population, again, focusing on acute leukemia and MDS, and then just 7 of 8 mismatch. And their primary objective was to compare overall and GVHD-free or Griffiths at 2 years post-transplant between those based on the locus of mismatch. And we included DQ and DP in the analyses to determine whether they influence those outcomes. This was 1,255 patients from 114 centers. Majority had acute leukemia, generally a bit older, and a generally younger donor population. So the median donor age was 27.7 years in this cohort. 52% were female. Again, this is a mismatched population, and 32% were ethnically diverse. 93% received peripheral blood stem cell grafts. HLA-A was the most common locus mismatch. That's not uncommon. That's what we see currently in the 7 of 8 setting. DQB1 mismatches were more common among the DRB1 mismatches. That's not unexpected. There's tight linkage disequilibrium between DRB1 and DQB1. So if DRB1 tends to be matched, 95% of the time you are also matched at DQB1. HLA-DPB1 TCE matching was similar across the groups, ranging from 20 to 27% non-permissive. When we looked at the impact of DQ and DP in these models, again, all in a post-transplant cyclophosphamide-based GVHD prophylaxis setting, we saw no impact of DQB1 or DPB1 on any outcomes. So at this point in this population of about 1,200 mismatch cases, we feel like we could set aside DQ and DP matching if there are no anti-HLA antibodies against those loci to result in a donor-specific antibody reaction leading to higher rates of graft failure. So always need to consider that in the presence of anti-HLA antibodies and the mismatch that is present. So looking at the primary outcomes of overall survival and GVHD-free relapse-free survival, we don't see any difference between any of the loci. And when we look at secondary outcomes, again, we see no significant differences between any of these outcomes. So to me, this is good news in the setting of post-transplant cyclophosphamide GVHD prophylaxis. You can use the entire donor pool, not having to restrict for particular HLA mismatches that maybe are worse than others. And so this is an analysis in 1,255 patients. We just completed drafting and submitting an abstract to ASH, where we've extended this through 2024, and these results still hold. So we increased the population by 30%, and we still don't see an influence of any particular locus on any outcomes of interest in transplant. So suggesting that any 7 of 8 donor would be a good donor in that setting. So in this large contemporary cohort of 7 of 8 mismatched unrelated donor transplants, we didn't observe any differences based on the locus of mismatch, and that includes mismatches at DQB1 and DPB1 T cell epitope matching, which was evaluated in this analysis as well. So these results support mismatched unrelated donor selection strategies that prioritize non-HLA donor characteristics. Younger donor age did enter into the overall survival, Griffiths, and non-relapse mortality models, suggesting that does still have influence in the PT size setting. So I mentioned our donor selection guidelines that were published last year. Here's the citation for that. And here's the main summary of HLA matching and recommendations in the modern era. So in the calcineurin inhibitor setting, avoiding DPB1 non-permissive mismatches in matched unrelated donor transplants. In the mismatched unrelated donor setting, really you should be using a PT-Cy-based strategy or some other alternative GVHD prophylaxis approach if you do need to use a mismatched donor. In the modern era, there are better ways to do this than just straight up calcineurin inhibitors. In the PT-Cy setting, HLA-DPB1 mismatched haplos may be protective against relapse. HLA-DPB1 TCE non-permissive mismatching may be associated with better survival in the haplo setting. But in the MUD and 7 of 8 mismatched unrelated donor setting, outcomes appear to be similar, and there doesn't appear to be any influence of the underlying locus of mismatch, nor of DQB1 or DPB1 T cell epitope matching. So there's insufficient evidence really to recommend prioritization of specific HLA mismatches between mismatched unrelated donors in the PT-Cy setting today. And that's extending those results even out to 1,800 patients with 7 of 8 mismatches, or 7 of 8 matches. Highly mismatched unrelated donors, which I didn't touch on here, we do have an active we've had several active clinical trials that have demonstrated the ability to use multiply mismatched donors using PT-Cy-based approaches. So that's down to a 4 of 8 or less. We have a paper that was just accepted in Blood Advances that shows that contrasts 7 of 8 versus less than 7 of 8 matches from our ACCESS clinical trial, which used full dose post-transplant cyclophosphamide-based GVHD prophylaxis. So that's 50 milligrams per kilogram on days 3 and 4, and showed no difference between 7 of 8s and less than 7 of 8 matched. Now, the majority of the less than 7 of 8s were 6 of 8 matched. So that's like 85% of that population. So we can kind of comfortably say that 7 of 8s and 8 of 8s, 7 of 8s and 6 of 8s look pretty similar, but again, more that needs to be investigated in the less than 6 of 8 setting. But then again, we have decades of experience in the haploidentical setting demonstrating that a 4 of 8 works quite well using post-transplant cyclophosphamide-based GVHD prophylaxis. And last but not least, the donors with high titer donor-specific antibodies. So I didn't go into much detail about anti-HLA antibodies. Patients can be exposed through transfusions or through pregnancy, can become sensitized to non-self HLA, which can create a barrier to engraftment post-transplant. And so really should be screened in the setting of mismatched transplantation. And frankly, when we consider HLA-DP and DQ, the vast majority of matched unrelated donors truly do have a mismatch somewhere, and so should be screened for the potential for anti-HLA antibody interactions. All right, and with that, I'm going to switch over to our case studies. I'm happy to make this interactive if people want to come off mute and comment or ask questions. But let's just walk through the first case. So this is considering a calcineurin inhibitor-based GVHD prophylaxis setting. So you have a 59-year-old female, non-Hispanic white with high-risk AML in CR1 with high-risk features. Patient has underlying cardiac comorbidities that contraindicates the use of cyclophosphamide for GVHD prophylaxis. They happen to be adopted and have no known biological relatives. An unrelated donor search identifies several available options. So which one would you choose? So first option is a 45-year-old 8 of 8 male, matched unrelated donor, DQB1 match, DPB1 TCE permissive, but with a 5,000 MFI, or mean fluorescence intensity, donor-specific antibody against the mismatched DPB1 allele. Option B is a 25-year-old 8 of 8 female, matched unrelated donor, QB1 match, TCE non-permissive mismatch with no relevant DSA, and then a 35-year-old 8 of 8 male, matched unrelated donor, DQB1 match and DPB1 TCE permissive with no relevant DSA. So I'm happy to take a question or a recommendation, or I can just give you my thoughts on this. So with this one, considering the impact of donor-specific antibodies, I think we would take A off the table, since we do have 2 viable options for other donors. Between a 25-year-old female and a 35-year-old male with similar features, however, the female is a TCE non-permissive. But as we saw in our modeling on donor features that are important, age would trump a non-permissive DSA or a non-permissive TCE. So personally, I would lean towards B, and C is not a bad choice at the end of the day either. So 2 good options that are available. All right, well, let's move on to the PT size setting then. So case number 2, so we have a 65-year-old male with high-risk AML in second chronic remission or complete remission. Allogeneic transplant using a PT-SI-based GVHD prophylaxis strategy is planned. This patient has no siblings or biological children, and unrelated donor search identifies several available options. And which would you choose? So A is a 23-year-old male, matched unrelated donor, DQB1 match, DPB1 TCE permissive, but again has that MFI to a DPB1, to the mismatched DPB1 allele. 30-year-old 8 of 8 female, matched unrelated donor, DQB1 mismatch and DPB1 TCE non-permissive mismatch and no relevant DSA. And then a 40-year-old 8 of 8 male, matched unrelated donor, DQB1 match, DPB1 TCE permissive and no relevant DSA. So couple decent options here. Probably stay away from the mismatched DSA here if possible. And likely would lean towards the 30-year-old female. Just with the modeling that we've shown that DQB1 doesn't matter much, DPB1 doesn't appear to matter for any outcomes. There's no relevant DSA, and you're getting the advantage of a younger donor in this setting. And they are of equivalent of sufficient size to give the graft that you need for that patient. Although a 40-year-old 8 of 8 male, not a bad choice again here at all. And so that's one thing that I want to emphasize with the age cutoffs and the age thresholds that we discuss. Those are not red bright lines by any means. If this is the only donor available, your 40-year-old donor is the only one available, that's a great choice at the end of the day. You're taking on some additional risk with the older donor age, but at the end of the day, it's still a good donor and a good option for your patient. So last but not least, we have a 45-year-old Hispanic white female with high-risk AML in first complete remission. They're getting an allo transplant using myeloablative prep and a PT-SI-based GVHD prophylaxis strategy. They have one older matched sibling with a history of MDS and one haploidentical 10-year-old daughter. An unrelated donor search identifies two additional options. Which donor would you choose? So you have the 10-year-old 4 of 8 haplo-female. They're DPB1 TCE non-permissive, have no relevant DSA. You have a 23-year-old 8 of 8 male, MUD, DQB1 match, TPB1 TCE permissive, but again, they have DSA against that DPB1 allele. Or a 30-year-old female, matched unrelated donor, DQB1 mismatch, DPB1 TCE non-permissive mismatch, but with no relevant DSA. Here, so a couple options probably here. I don't know what the policies are in South Africa, but generally in the US, we would not prioritize a 10-year-old female relative. Just small, young, and there are good unrelated donor options here. So a 30-year-old female matched unrelated donor probably is a good choice to go forward. So with that, I just to summarize, HLA-DPB1 T cell epitope impact in the calcineurin inhibitor-based GVHD prophylaxis setting, it impacts on outcomes appears to be limited to mainly acute GVHD in our contemporary CIBMTR analyses. Prioritizing TCE matched or mismatched when all other donor factors, especially younger age, are equivalent. Makes sense. So if you do have the choice to enrich for that, great, go ahead, but it isn't the end of the world. If you are not able to find that TCE permissive donor and you have good young donors available. HLA-DPB1 T cell epitope matching does not impact outcomes or doesn't appear to associate with any outcomes in the unrelated donor PT-Sci GVHD prophylaxis setting. So findings in the haploidentical setting do not appear to translate currently to the unrelated donor setting, although we'll continue to evaluate that and offer more guidance as we have more data available for recommendations along those lines. And with that, I just want to acknowledge all the transplant centers who support the mission of the CIBMTR by providing data, all of those patients who have enabled us to learn from their transplant journeys, all of the donors that are willing to donate for a stranger, give them a second chance, and then our funding sources. So with that, I'll go ahead and close, and I'm happy to take any questions that people may have. So thanks.
Thank you very much, Steve, for an excellent talk, as always. I particularly enjoyed your slides at the end where you did the summary, the conclusion summary of, because that impacts the registry people as far as HLA goes, and some of the choices we may make. So that was great to see, and it's always nice to have a summary of that nature. I do see a hand. I see Andrew McDonald has got a question for you.
So thanks, Steve. Some comments and then maybe a response to them. So just the use of underage or of minors, especially related minors, especially in our center, is really frowned upon. Our donor coordinators and advocates really are not in favor of that. But just to say that in South Africa, I'm sure you've been aware that for many years we've used ex vivo alemtuzumab and then followed by a calcineurin inhibitor as our GVH prophylaxis of choice. But given supply issues and etc., we've kind of almost, well, at least we have gone lock, stock, and barrel essentially over to PT-Sci. Including matched related donors. So that's just been a kind of forced upon us. Without really to be even making a decision, we kind of one day we had to do that one regimen, and the next day we had to do something else. So we've actually seen a little bit of uptick compared to the alemtuzumab in some GVHD, especially in gut GVHD. We've had some issues in some patients. But I think just then another comment is that more than anything in the real world, cost dictates which donor we can choose. A lot of our in fact, actually, most of our patients in South Africa do not have access to international registry. They're restricted to South African And that really becomes a problem. I mean, obviously, and there's a lot of our Black patients where we actually see a lot of donors sitting in the NMDP and Brazil, and most of them, because of cost, don't have access to those donors. So in the real world, yeah, we cost first, and then we ask questions afterwards about, can we find the best donor? Looking at once we've got that in hand.
All right. Well, thank you for those comments, and I appreciate the additional background on the recent changes in South Africa and how you've transitioned to a PT-Psi setting. Interesting to hear about the potential increased risk of lower gut GI GVHD. That might be something worth some discussion. And there's some new data coming out of the CIBMTR GVHD Working Committee that does compare kind of calcineurin inhibitor, not necessarily the alemtuzumab setting that you were discussing, but different approaches and what's seen in the manifestation of GVH and how that's evolved with these changes in GVHD prophylaxis. So be interesting to see if that reflects the experience that you've had as well. Just if I can ask, even with the do you utilize mismatched transplants much out of the registry, or is there a limit to the mismatches that can be accessed at this point?
So we've gone. We've gone quite a few 9 out of 10. So obviously we were at 10, but we have done searches for 8 out of 10. I don't think we've actually got to an 8 out of 10 yet. All the patients that we kind of had targeted for that were, once we're down there, we're into, they've got a really high risk disease. And I think most of them actually progressed before we actually got the 8 out of 10 donor. So we're quite willing to do that. And in fact, just in terms of our, we're benchmarking compared to EBMT. I mean, we've got double the haplo rate that sort of Europe has, obviously because of our lack of access to donors, where we're doing a lot more haplos. Less in recent times, we are getting more coming back online with MUDs, but historically and still recently, we're a lot more haplos than many other centers in the world.
Okay.
Thanks, Steve. I see, and thanks, Andrew, for raising that issue. I was going to also ask about the age, if there was a cutoff on your younger donors. So that's great. And then, Cecile, I see your hand's been up for a little while.
Yeah, thank you, Stephen, for a wonderful talk. Just one thing which I'd like to confirm. In all your studies, your dose of PT-Psi is 50 milligrams per kilogram. You've not gone lower in your MUDs or smash MUDs?
Well, the data that I shared today was mainly 50 milligram per kilogram times 2 on days 3 and 4. That's kind of standard dose. What I didn't share is we've had a clinical trial that will be presenting results at ASH called Optimize, where we are looking at a reduced dose PT-Psi in the mismatched unrelated donor setting. And so the primary outcome for that trial was 100-day infection-free survival. And so we'll be reporting those results out. But there we went down to 25 milligrams per kilogram times 2, so half the dose that was used. Anecdotally, we do see more acute and chronic GVHD using that approach, although our non-relapse mortality was much lower, and overall survival was essentially equivalent to what we see, if not a little bit better than what we see in the full dose PT-Psi setting. So more to come on that. So there's some risks with modifying the doses. While we do have another clinical trial that is just starting, where we're in a safety run-in pause at the moment. It's called the Accelerate trial, where we will be using reduced dose PT-Psi in a randomized setting. So we have a full dose PT-Psi backbone as our control group, and then compared to a 25 milligram per kilogram reduction. So half dose either with adjuvant abatacept or ruxolitinib added to either of those arms. So that more to come on that in the future, but as of right now, it doesn't feel like just reducing the dose is sufficient. Reducing the dose can decrease some infection-related toxicities, but does increase that risk of acute GVHD. So or chronic GVHD. So kind of looking at other ways to mitigate that in the future.
Yeah. And these are all, is this mostly using peripheral blood stem cells or bone marrow?
Yes. Those trials are using peripheral blood stem cells. And as I noted in these presentations, it's about 90% of these are using peripheral blood stem cell grafts in what we've reported today. Okay.
And I do see, Estelle, you had your hand up, and I also see Matt is on the call and he's had his hand up. So maybe Estelle first.
Yeah, it's great to listen to you, Steve. It's amazing data, such great groups of people, big groups, which we don't always have. I just agree with Andrew. We do a lot of haplo transplants, and we at my center there is a majority of people of African origin. So we really had no access until the donor pool has grown. And this is actually a question also for Charlotte. As Andrew also said, he said now and then a 9 out of 10. I must say we're very much at the beginning of it, because getting the donors actually that come up as 9 out of 10 is not always so simple. So I wonder, is it because there are no 8 out of 10 donors that we never get to 8 out of 10? Is it like what I'm trying to say by that, is there a kind of a predilection for, in our population, more 9 out of 10 matches and not 8 out of 10? I see, when I look at European and American data, a lot of the 7 out of 8, 8 out of 8. It's not as if it comes up. Is it simply that we don't go there? Or I don't know, if an impression from either of you regarding that. And then my last point about this Accelerate, I think it's the Accelerate that you mentioned, or perhaps the trial that you mentioned after that. You start with the ruxolitinib early, directly after transplant, or only after engraftment in that trial? Just wondered. But let's go to the other question first. Sorry.
So perhaps I can just come in there, Estelle. When we do the report, we actually can see all the donors that, and how well they matched. So we would be able to look into that for you. And
now, of course, you see them, but the question is,
Yeah.
we never kind of pay attention to them. And I was just wondering why. Is it because we don't want to pay attention, or because they're not there?
I don't know if it's not there. And I mean, I'm not sort of actively transplanting, but I would say that is it not just because we are a bit cautious on using unmatched
Could be, and that there is then a
genuinely-
haplo donor that's easily available and so on. We may be looking, but not necessarily accessing the donor.
Yeah, I think it is more that, because we do rely on what, the transplant center doctors coming back to us to say, oh, we would like to look at this donor, or which is why we provide the full report. But yeah, I can understand as well why. I mean, you don't really want to do mismatched donors unless you're very experienced or you've got some previous experience.
Yeah, I can't remember that we ever actively, did not want to do it. We realize our lack of experience, so we are obviously cautious, but it's not that we have let go of great 8 out of 8 donors on purpose. I think it's been often kind of foisted on us, and Andrew spoke about cost. That's obviously one reason, but the other one would be because donors are not available, or as I said, perhaps there's a kind of a gap in the availability. Okay, so just I thought Steve may also have some comment on that, and then it's the Ruxo question.
Well, on the multiply mismatched unrelated donor setting, we're generally doing that on clinical trials at the moment. So the Accelerate trial that's open now, and so any patient that's enrolled on that trial would have access. to those multiply mismatched donors down to a 4 of 8 level. Although that isn't our common practice at NMDP as far as match source is concerned, I think you can get access to a 6 of 8 roughly, but then would have to specifically ask for a multiply mismatched search to gain access to those that are mismatched below that. So it's not general practice to present those up front. But then again, the majority of patients will find a match, like 99% of patients will find a match at the 6 of 8 or better level on the US registry for US patients. At least that's what our modeling suggests at this point. So, and then sorry, it was a question about the ruxolitinib on Accelerate. That's started at day 15 post-transplant.
Day 15. Okay.
Yeah, day 15.
And at 5 milligram or?
What's that?
Day 15 at 5 milligram, at 10?
I believe it's 5 milligram, but I'd have to double check.
Probably a low dose. Yeah. Okay. No, that's interesting.
Okay.
Yeah.
And thanks, Steve. And then Matt, I see you've had your hand up for a little while.
Yeah, thanks very much. Great presentation. Steve, hi, nice to hear from you. I'm obviously on your side of the Atlantic, but take the South African activities to heart. So just to ask you a question, I'm going through your algorithm that's well accepted in the US as regards to CMV. So I think our colleagues in South Africa are unlikely to have access to letermovir and probably have more sort of historical approaches to CMV prophylaxis and management. Correct me if I'm wrong, Estelle and Andrew, but I don't think letermovir is.
We had a couple of patients on letermovir, and then the medical aids realized what we were pushing through in costs, so it's disappeared. And
Right.
I think it comes about to just deregister the drug because they're not selling it.
Okay, thanks. So I think that the reduction, the de-emphasis of CMV matching with respect to donor selection in North America has been in tandem with the increasing availability and use of letermovir. So I wonder about the importance of CMV matching in the South African setting when you, for the foreseeable future, won't have access to this drug.
That's a good question.
Question and a statement.
Yeah, I mean, when we look back at the associations between CMV, donor CMV status and mortality, we really don't see an effect. However, that doesn't take into account any of the morbidity that would be associated with the infections. And so there may still be benefits to selecting for a CMV positive donor in the setting of a CMV positive patient. But how effective that adoptive transfer is of the CMV immunity is frankly not real clear to me, and it's hard to kind of tease out of these large registry studies. But something that I mean, I'd love to hear from the South African team and as far as how you select and if you prioritize donor CMV status and you see some benefits of that. Where I don't really see much in the data is where there is like donor CMV positivity and any actual transfer to the patient, like de novo development in a CMV negative patient due to a CMV positive donor. But again, that's limited experience, I think, on my part. So.
I'm going to guess that most of the donor population in South Africa, be they related or unrelated donors, are going to be CMV positive anyway. There's not a whole lot of choice there with respect to donor CMV status. I'm guessing that. Correct me if I'm wrong.
And patients, obviously, both.
Yeah, exactly. So you basically just got to pause cohorts naturally.
All pause. Okay.
Yeah.
Yeah, I mean, just to comment, I mean, in the black population, probably that's right, but we do run about 10-15% higher CMV seroprevalence rate even in the white population in South Africa. So I think when we're accessing some European donors, which have a lot lower rates of CMV. And that's where I think we're seeing the most of recipient positive, donor negative pairs.
Thanks. I just want to squeeze in one little question again to Steve, just for another 30 seconds, if you wouldn't mind. Is that, Steve, I just want to clarify that the majority, if not all of the data you showed about mismatched unrelated transplants with PTCY is in the malignant setting rather than the non-malignant transplant setting. And I say this because I think that South Africans are faced with a fairly large number of patients with aplastic anemia and perhaps some other non-malignant disorders. So I don't think it's transferable to the non-malignant setting, but correct me if I'm wrong.
You're correct that the majority of all of the data that I showed essentially was in the malignant setting. That tends to be the majority of the transplants that are performed, and they tend to be kind of uniformly treated, at least acute leukemia and MDS, prior to transplant. So that's why we tend to focus on those populations. But there has been some really interesting data coming out of mainly the Hopkins group in severe aplastic anemia. So studies led by Amy DeZern using post-transplant cyclophosphamide-based strategies and haplo-identical related donors, and showing very positive outcomes there. And that group is actually starting to advocate for upfront haploidentical on PTCy-based GVHD prophylaxis allo transplant as upfront therapy in severe aplastic anemia. So moving away from just only matched SIBs or only matched unrelated donors, but then looking at alternative donors as well. So more work that's ongoing there. There's an active trial in the Blood and Marrow Transplant Clinical Trials Network that's evaluating that. So more to come in the non-malignant setting, but does appear to be effective at this point. We'll see where that and how that extends into the unrelated donor setting as well.
Thanks. And I think I saw Cecile's hand up again. Cecile?
No, I just also wanted to raise the issue that we have mostly CMV positive donors and recipients. And
All right.
Okay. Okay, so I think then that brings us to the end of the talk. And thank you again, Steve, for doing the talk. I think it's been a great help to some of our guys and wait, Deborah Vaz, you've got a question. Just one more question quickly.
Hi, Charlotte.
Hi.
Hi. Sorry, I just one quick question to Stephen. Thank you very much for your talk. I really enjoyed it. It's very close to what I'm doing at the moment for my thesis. So thank you very much for enlightening me. I just have a quick question about your study, specifically on the machine learning. One of the parts of the study that you actually mentioned, and I think it's a big, not problem, but it's one of the aspects that I've noticed is that the majority of the cohort in these studies is Caucasian. So that is mentioned in your study as well. And I'd like to know if you think we might find something different if we studied, non-white populations. Have you seen anything out there? Has anything been done on studies that are of lower representative groups in the US? Just out of curiosity, I wanted to know your thoughts on that.
Yeah, no, and good observation. I mean, in the fully matched setting, it does tend to be a white non-Hispanic population in the US, so about 85% or so. In the mismatch setting, though, we are seeing about a third of the population. So that data that I shared on the 7 of 8 matched, we did include over nearly a third were non-Hispanic, non-white. And we didn't see a difference based on race and ethnicity within that population. We also include race and ethnicity in what we call our center-specific outcome analysis. So this is an annual report that we do for the as part of a contract that we have with the Health Resources and Services Administration of the U.S. It's a benchmarking exercise where really we're looking at the performance of centers. So the 178 or so centers that perform allotransplants in the US and looking at their 1-year survival. And the patient race and ethnicity is always included in that analysis. And for the last, I think at least the last 6 years, we have not seen an influence of race and ethnicity on 1-year overall survival. Now, that doesn't say that there aren't other risk factors, but it's not manifesting in mortality in that first year post-transplant. Not to say that everything is on a level playing field right now, and we do continue to consider race and ethnicity in all of our analyses to see if there are differences, because we do know things like drug metabolism can be very different across populations. And so something that we do need to consider in that setting. And so we'll continue to look for it, but as of right now, we're not really seeing any signals that would point to a difference in the use of mismatches in the PT-Sci setting based on race or ethnicity.
Okay, great. Thank you so much. Thank you
You're
for your
welcome.
talk.
My pleasure.
Thank you.
All right.
All right. I think, Steve, we're going to let you off now.
All right. Well, thanks, Charlotte. I appreciate it.
Thanks again.
All right. Take care.
Okay, you too. Bye. Bye, everyone.